Knee bursitis. Now, this is a pet peeve of mine. You should never give a diagnosis of bursitis until you figured out the cause. Like it could be knee bursitis secondary to internal derangement of the knee bursitis secondary to meniscus tear, knee bursitis secondary to an ACL tear, chondromalacia patella potentially. All of these things, you need to find the cause of the bursitis. So let's go ahead and have a look at this. It is a pet peeve I have for doctors and therapists who come up with this as their diagnosis. You might as well say the person has eyeballs, okay, or swelling. You have swelling. Well, yeah, knee bursitis doesn't really tell me too much. It tells me that I need to look deeper and figure out what the real cause of the pathology is. So inflammation of a bursa around the knee almost always exists secondary to a knee pathology. Even in rare cases, it could be an infection, potentially. So there are approximately 12 bursa around the knee. Most commonly affected are iliotibial band bursa, so out around the lateral side, Pezan-Serine bursitis around the medial side, where sartorius, gracilis, and semitendinosus run. You could have a Baker's cyst at the back of the knee. You could have prepatellar bursitis at the front of the knee if you wanted. There's subcutaneous infrapatellar bursitis. There is deep infrapatellar bursitis, suprapatellar bursitis. The joint capsule is actually connected all the way around, so it's not abnormal to see this connected and swelling coming out in multiple areas with injury to the inside of the knee joint. Don't just call it bursitis. Excessive mechanical stress, tissue damage, irritation, or inflammation. Some people will call this water on the knee. That's a very old generic term, but water on the knee. Bursitis anywhere in the body has been estimated about 4% of primary care visits, or 0.4%. Runners maybe up to 10%. I see it a lot more in football players and soccer players with this water around the knee because of the cleats and the increased risk of knee injuries. Peak age, 35 to 80, gender is equal. Excessive physical activity is a major risk factor with obesity, knee instability, osteoarthritis, or meniscal damage. Yes, those are causes of bursitis. Occupational, if you're spending a lot of time on your knees as a maid or construction worker. I've seen this in a few tilers that do this. So direct knee trauma, casting or bracing, pressure, I should say. Local tendinopathy or tissue contracture, chronic overpronation potentially could be there. Pes planus gets a little bit murkier here in the literature as you start to look at these causes. And some studies even indicate diabetes as a risk factor as well. Okay, history, dull, achy pain, or a pressure sensation. This is the biggest thing. It feels boggy. It feels swollen. If the person is lean enough body mass, you can often see the swelling around the knee. History of athletic or work activity that causes increased knee stress as a risk factor. Local swelling is your finding, okay? But again, figure out what is the cause of the swelling. They might have an antalgic gait. Palpation might show a boggy end feel. You can actually milk the joint and move the fluid back and forth potentially with this. You can look at active and passive range of motion, maybe within normal limits, or maybe limited due to pain or swelling. Again, a boggy, spongy end feel with passive range of motion. Resisted range of motion is within normal limits unless you have a coexisting muscle or tendon weakness with it. Neurovascular screen should be within normal limits. It is this author's opinion that bursitis should rarely be given as a diagnosis, as it is usually secondary to another pathology. So you can look for the other pathologies. You have to rule out infection, absolutely. So look for that swelling, that redness, puncture wounds. Maybe they have a fever, they're not feeling very well, rapidly progressive, not really following an injury type pathway. Ligamentous ruptures, you can look at our videos on that, or you know well enough how to figure that out. Muscle strain, fibromyalgia. I'm kind of grasping at straws with the fibromyalgia. Osteoarthritis may be a little more likely. Stress fracture, if they have the right history of a repetitive event. Meniscus tear, more likely going to cause the bursitis. Osteochondritis dissecans could. Osgood Schlatter's should be lower on your radar here. Again, tenderness over the tibial tuberosity, usually adolescent kid who's taken up an activity or very active. Special tests, any stress test over top of this area could potentially result in symptoms. But again, they are going to identify the primary pathology causing this secondary bursitis. Diagnostic imaging is usually not indicated unless you are trying to rule out other pathologies. Ultrasound and MRI are going to be your best choices here. This is a great picture from Gray's Anatomy showing the connection of that bursa all the way around. Fantastic. The patella may float a little bit if it's bad enough. You can do a patellar ballottement test. I didn't even put, oh yeah, I did put it there. Patellar ballotment test where you can just push down on it and look for it to be springing back and forth. All right, general measures. Consider price, consider meth, one-on-one basis. Again, the research is kind of moving away from the compression rest ice methodology, more towards meth or movement, correctional postural deviations if they are there for the underlying factors. So you have knee bursitis, massage therapy is a great choice. You can do gentle mobilizations and any of your myofascial Swedish type techniques. Even in acute cases, really severe lymphatic drainage might offer some benefit as well. Osseous mobs can offer benefit, focusing on areas of compensation, lumbar and SI, evaluating for leg length inequalities if they are contributing potentially. Electrotherapies and acupuncture also can offer some benefit. Medications, short-term use of NSAIDs can be there. You could look at a Prolo or PRP injections later on if your conservative pathways haven't worked. Or if you want to be more specific and identify the specific cause of pathology and it's an ACL tear or infrapatellar tendonitis or something. And again, conservative management hasn't worked. Surgery is rarely required. Again, identify the cause. If they have a bursectomy done, they often reform. So yeah, if there's a bony exostosis, that could be there. Again, yeah, that can be removed, but the bursa may reform if there's still irritation or they might have sensitivity from it. But surgical options, after all conservative managements have been attempted, then you can look into that as an idea. Rehabilitation program, use superficial heat and stretching prior to exercise. Okay. Ice after exercise, possibly. I do this on a case-by-case basis for individual clients and patients. Stretch and strengthen the knee. You are not going to go wrong with stretching and strengthening of the knee. Patient monitoring, initially during the acute stages, you might see them a little bit more frequently just to make sure that you haven't missed something or other pathologic signs don't show up for another pathology. Educate the patient, okay? Proper footwear, especially if the patient overpronates. Leg length inequalities, if it's contributing during the training, proper warm-up is going to be key for every activity. If it's an obesity issue that's leading to osteoarthritis or patellar tendonitis or something, you get more than the biomechanical benefits from the weight loss. There are so many other health benefits if you can get their weight normalized. Consider sleeping with a small pillow between your knees. Absolutely, that is huge. And prognosis, usually excellent with conservative care. Most people should expect a full return to activity. Miscellaneous, you could look at some bursitis for the pes anserine. Baker's cysts, swelling at the back. Sometimes these do become fluid filled and more significant, often associated with osteoarthritis. Again, I cannot stress this enough. Pun intended, do not diagnose bursitis. Find the cause of the bursitis and then start working on that pathology. Otherwise, you're only putting a Band-Aid over the treatment when really we need to be more specific in identification of the pathology. Education, empowerment, graded exercise exposure, and then our manual therapies come out to also facilitate optimal healing. So here we see an excellent review of knee bursitis, super quick for us to look through. I thank you very much for your time, and I will see you on the next video.